Dr. Bibin to say a few words by the time we go to the Dr. Bibin, please.
Bibin unmute.
Yes,
Yeah,
sir.
okay.
Sir.
Yeah, Bibin, please.
Am I audible?
We are on the air.
Yes, sir. Yes, sir. Actually, Dr. Ranjit has already informed about the TOT, eminence member TOT. Only thing I want to focus is be more genuine and be it in a sportsman spirit. അതായത് നമ്മളൊരു ഓൺലൈൻ മീറ്റിംഗ് ആണ്, പല ക്വസ്റ്റ്യൻസും വരും. അപ്പം നമ്മൾ ഒരു AIO അല്ലെങ്കിൽ ഒരു സോഷ്യൽ മീഡിയ ലൈക്ക് ഗൂഗിൾ അല്ലെ അത് നോക്കിയിട്ട് നമ്മളൊരു ആൻസർ പറയുന്ന ലെവലിലേക്ക് പോകാതെ മാത്രം നമ്മൾ പെട്ടെന്ന് തന്നെ റിപ്ലൈ ചെയ്യണം. ഇതിനകത്ത് നമ്മൾ ശ്രദ്ധിക്കുന്നത് ഏറ്റവും ബെസ്റ്റ് ടീച്ചേഴ്സ് അല്ലാതെ ആൻസർ ചെയ്യുന്ന സ്റ്റുഡൻസ് അല്ല, നല്ല ക്ലിനിക്കൽ ക്വസ്റ്റ്യൻസ് അല്ല, ഗുണ്ട് ചോദ്യങ്ങളല്ലാതെ ചെയ്യുന്നവരെയാണ് നമ്മൾ മാർക്ക് ഇടുന്നത്. അപ്പൊ അത് മാത്രം നോക്കുക, നമുക്ക് പ്രൊസീഡ് ചെയ്യാം. താങ്ക് യു സർ.
Thank you very much. We are at 8:05. The first team is GMC Kottayam. You can make the presentation. 5 minutes right now for you. You can share.
രണ്ട് ടീം ഒന്ന് ഇൻട്രൊഡ്യൂസ് ചെയ്യാൻ സാറേ.
The teams are GMC Kottayam versus Sri Gokulam Medical College Venjarama.
Sir, screen share ചെയ്യാൻ പറ്റുമോ sir? PowerPoint.
Yeah, share ചെയ്യുന്നു.
Sir, I don't know. Screen share. Sir, host is disabled.
Sir, host disabled screen sharing ആണ് sir.
അല്ല, നിങ്ങൾക്ക് ഷെയർ ചെയ്യാം. എനിക്ക് പെർമിഷൻ അയച്ചിട്ടില്ല ഇതുവരെ.
Host disabled attendee screen sharing.
ഞാൻ ഒന്നുകൂടെ ചെയ്യാം.
Yes, sir.
ചെയ്യാൻ പറ്റുന്നുണ്ടോ നിങ്ങൾക്ക്?
Try ചെയ്യട്ടെ sir.
Still same message answer.
Same message answer.
Same sir.
Yes, sir. One second, sir.
You need to ask me permission. I've given the permission.
Yes, sir.
It's correct answer.
Sir,
Yeah, go ahead.
Yes. Respected faculty and my dear colleagues, today we present a case of Miss X, 17-year-old female student from Kottayam, who presented with complaint of painful swelling in the left axilla for the past 1 week and pus discharge from the left axilla for the past 2 days. History of presenting illness. Patient presented with history of recurrent painful swelling and pus discharge from both the axilla for the past 2 years and now presented with swelling in the left axilla for the past 1 week. The swelling was insidious in onset, painful, gradually progressed in size and ruptured 2 days back. She complains of pain in the left axilla for the past 1 week, which was continuous throbbing type of pain, worsened over the past few days and was relieved on taking medication and also relieved once the swelling ruptured. She complains of purulent, malodorous discharge in the left axilla for the past 2 days. There is no history of pain or swelling in the groin, back, scalp, or under the breast. No history of loss of weight or appetite, evening rise of temperature. There is no history of yellowish granular discharge from the swelling. No history of excessive pimple in the face, scalp infections, pus discharge in between the butt cheeks. No history of altered bowel habits, abdominal pain, joint pain, or trauma to the axilla. Past history, there is no history of diabetes, PCOS, IBD, acne vulgaris, tuberculosis, or dyslipidemia. Treatment history, first episode was 2 years back in the left axilla, managed with topical antibiotics. Second episode, 4 months back in the right axilla, managed with oral and topical antibiotics. Third and the fourth episode occurred 2 months apart, managed similarly in the right axilla. Fifth episode in the left axilla, 6 months back, managed similarly. Family history, there is no similar history in the family, no tuberculosis, IBD, arthropathy in the family. Personal history, she consumes non-vegetarian diet, has a normal bowel and bladder habit with normal sleep and appetite without history of smoking or alcoholism or use of addictive substances. Menstrual history, attained menarche at 12 years of age with regular cycles and last menstrual period on 2nd April 2026.
You have just 2 minutes more.
Moving on to examination, patient is conscious and well-oriented with a height of 160 centimeters, weight of 60 kilogram, and a BMI of 21. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Her vitals were normal on examination. Local examination of the left axilla. On inspection, there is a single erythematous nodule of approximate size 1 into 1 centimeter along the posterior axillary fold with purulent, foul-smelling discharge. 2 parallel scar marks were noted around 2 centimeter below the nodule. On palpation, there was local rise of temperature. There is a tender erythematous nodule of size 1 into 1 centimeter, firm in consistency, fixed to the skin with surrounding induration and a sinus with seropurulent discharge. 2 linear scars were noted around 2 centimeter below the nodule of length 1 centimeter and 8 millimeter. There were no other palpable swellings. Local examination of the right axilla. On inspection, 2 parallel linear scar marks were noted along the skin crease of length 2 centimeter and 1 centimeter, which were nearly 2 centimeters apart. On palpation, there is a non-tender nodule of size 0.5 into 0.5 centimeter just anterior to the lowest scar. 2 parallel linear scar marks along the skin crease of length 2 centimeter and 1 centimeter, nearly 2 centimeter apart. Examination of the breast and nipple areola complex bilaterally was normal. Examination of other areas, the scalp, inframammary and intermammary region, perianal region, and gluteal region was within normal limits. Systemic examination, cardiovascular system within normal limits, all other systems, respiratory, abdomen, and central nervous system within normal limits. Summarizing, 17-year-old female with a 2-year history of recurrent bilateral painful axillary nodules with pustular discharge now, presented with painful nodule and purulent malodorous discharge in the left axilla with scarring in both the axilla. Diagnosis is hidradenitis suppurativa, bilateral axillar disease with active disease in the left side, early stage 2.
Team Banyavarma, you can ask questions now. You have 10 minutes for this.
That was a good presentation from GMC Kottayam. We want to ask you a few questions anyway. What were the chief complaints of this patient?
Pain in the left axilla with the discharge.
Recurrent discharge.
Chief complaints were pain and discharge.
Pain for the past swelling left axilla, pain and swelling left axilla for 1 week and first discharge for 2 days.
Yes.
Okay. Is there any premenstrual exacerbation of pain and swelling in the axilla for this patient?
No.
Should we need to ask that question?
Yes.
What is the significance? Why do you want to ask?
Hidradenitis suppurativa tends to flare up during perimenstrual time.
Mostly after the ovulation.
Mostly ovulation. So should be asked anyway. Did the patient had any restriction of arm movement? So including the left axilla, including the left arm and also the opposite arm. Did the patient have any restriction of arm movements?
No.
There is no restriction of arm movements.
What is the significance? Why should be?
Contracture, even though there are contractures present, scarring is there, but no contractures are there.
It is a
No.
complication of hidradenitis suppurativa.
Yes, if you also examined other areas as well, including growing. Did you?
Yes, yes.
It was all normal, right?
Yes.
If there are any lesions in the growing or in the perianal region, so can it happen? Why?
Yes, it can happen.
Hidradenitis suppurativa can also present in the perianal region, most commonly in males. As well, we have to suspect concomitant lesions like water can perineum in Crohn's disease, which is usually associated with HS.
Did her any of her family history was positive? Did any of her first degree family relatives had similar complaints?
No, there is no history, family history suggestive of hydrogenated suppurativa.
What is the importance of asking family history? Is there any significance?
There is a genetic component involved in the family history. Mostly, there's a not signaling pathway, which is coded by the genes of presenilin and nicardin.
Yes.
1/3 of the family members can have a positive family history, and that is also an autosomal dominant type of inheritance that is found.
Yes. Mainly gamma secretase. Gamma secretase is
Gamma
being-
secretase pathway.
Not signal.
Then incomplete penetrance.
Yes.
So she is a non-smoker, obviously. Is there any significance for asking smoking history?
Yes. Smoking is associated with hidradenitis suppurativa. There is very high risk. for
Smoking causes
person-
follicular hyperkeratosis, which causes occlusion of the follicle, so that the secretions which are pooled up in the follicles gets ruptured, and once it gets ruptured, it initiates the intense inflammatory reaction, meaning the pathology for painful nodules.
Also, smoking should be stopped anyways in the patient because it can persist the inflammation and will delay the wound healing in this patient. So the patient is non-smoker, right?
Yes.
Okay. Is there any significance of asking obesity? What is the BMI of this patient?
Her BMI was within normal limits.
21 was her BMI. The significance of asking for obesity is it's an important risk factor because there is increased pro-inflammatory cytokine release from the visceral fat. So obese patients tend to have more incidence of hidradenitis suppurativa.
Also, these patients have more adverse reaction of cardiovascular events. So obesity.
Also, there is the mechanical effect of increased friction because of increased
That's
thickness.
main important.
increased friction, skin fold, and the axillary preponderance in obese patients.
Obesity. Other than that, the adipose tissue can secrete androgens and can
That can
predispose to metabolic syndrome. All that can
cytokine
predispose to hidradenitis suppurativa.
So-
So, what were the inspection findings in this patient?
Inspection of. Sorry.
What were the main inspection findings in this patient?
There was a sinus with malodorous purulent discharge and a nodule of 1 into 1 centimeter along with 2 scar marks, parallel linear scar marks. And
What
the
was-
right axilla, there was only scar marks with a non-tender nodule, no active discharge or sinus.
What are the pathognomic lesions of hidradenitis suppurativa?
deep-seated nodules, abscesses, scarring, tunnels, and contractions.
Have you heard of any double-ended comedones?
Yes. They are also called pseudocomedones. They appear as polyporous lesions and in groups.
Did this patient had any of those?
No,
this
there are
patient
no
did
comedones.
not
Had
have
not
any.
zero. She
Okay.
had not progressed to early stage 3.
Let's see. Okay.
What is the importance of what kind of scars you get in these patients?
It is bridging type of ropey irregular scars that is found in hidradenitis.
Any lymph nodes were palpable in this patient?
No.
No, there are no lymph nodes.
What group of lymph nodes should you need to examine?
Axillary.
Axillary
You
lymph,
have not examined any inguinal lymph nodes for supraclavicular, right?
yes, inguinal cervical lymph nodes has to be examined for tuberculosis, which is a rare differential diagnosis in this case.
Yes. If the lymph nodes are palpable in this patient, what-
If lymph nodes were palpable, we have to suspect tuberculosis as well as very rare sexually transmitted diseases like lymphogranuloma venereum.
so what are the major areas you need to look for in a patient with hidradenitis suppurativa under local examination? Major areas.
Main things are mostly axilla, groins, perianal region, intermammary and inframammary regions.
Okay. Is there any skin plasticity in the axilla? I mean, whether there was any underlying deep plasticity to the underlying muscles, including pectoralis major, anything like that in this patient?
No, there is no muscle involvement.
So the lesions were involving only
Skin and subcutaneous tissue.
What is the etiopathogenesis of hidradenitis suppurativa, and what is the importance of apocrine gland activity in this case?
Hidradenitis suppurativa occurs, they are relapsing chronic inflammatory condition of apocrine glands and characterized by deep-seated nodules, abscesses, tunnels in the apocrine gland rich areas. And
Etiopathogenesis
etiopathogenesis
is
Follicular hyperkeratosis causing occlusion of the follicle, so that the secretion gets pulled up, follicle ruptures, so that the contents of the follicle come to the subcutaneous tissue, and it elicits an intense inflammatory reaction. It is a purely inflammatory reaction, but the secondary infections can be superadded.
Follicular occlusion is the primary pathology. This apocrine gland activity can only occur as a secondary part. Apocrine gland is typically not the major cause for hidradenitis.
Follicular,
It's not
follicular occlusion causing hyperkeratosis. You named a staging in this, right?
Yes.
Can you just explain the staging in hidradenitis suppurativa and how does it complement your management?
The Hurley scoring is actually clinical scoring system, which is consisting of 3 stages. Our case is a stage 2 disease. Stage 1 will consist of recurrent characteristic inflammatory lesions without scar or sinus formation. Stage 2 disease is where there is interconnected multiple scars and sinuses, but with normal area in between them. And in stage 3, there are recurrent inflammatory lesions with scars and sinuses with no normal skin in between them, involving a wide area, interconnected multiple tunnels.
And how does it complement your management in this case?
Actually, the scoring system has a limitation because it does not take into account the flare-ups, prognosis of the disease, or remissions and treatment response. So there are actually modified scoring systems also, like modified hidradenitis scoring system, IHS4, which is International Hidradenitis Suppurativa 4 scoring system, and also AN, which is abscess nodule count, which is a very simple, which we can use daily on the OP basis.
These scores are more complex, so we are using only early stage at present to decide the management of the patient. Okay. Current management, how to decide the management of this patient, we are using only early scoring.
Okay. Can you just explain on the management that you're planning on this patient?
So we basically diagnose hidradenitis suppurativa clinically. Since this patient has a pus discharge, we would like to do a microbiology of the pus discharge, and in refractory cases we can do histopathology, a biopsy of the lesions, and to rule out any other differential such as tuberculosis. And we should also do blood workups in chronic cases to rule out anemia, hypoalbuminemia, and we should also do ESR.
Management is mostly multimodal. First, chronicity of the disease should be explained to the patient since it is a young age female. She should be counseled psychiatrically. Then lifestyle modifications such as obesity, smoking cessation, alcohol cessation, everything should be explained. Then I will be managing the pain of the patient with analgesics. Loose organs.
What are the historical?
You have 2 minutes more.
On histopathology, there will be follicular hyperkeratosis. There will be scarring, tunnels lined by either granulation tissue or squamous epithelium. We can find granulomas.
So is there any importance of any imaging modality in this case?
Yes. We can use ultrasound for superficial mapping of the disease if we are planning for excision. And we can do a MRI to assess deep diseases, mainly in perineal diseases.
Okay, can you explain some differential diagnosis also? Your first diagnosis is hidradenitis. Can you explain on the other differential diagnosis for this condition?
We would also like to consider differentials such as furunculosis, carbuncle, recurrent sebaceous gland cystic infections, and TB, actinomycosis, sporily.
Okay, how can you differentiate it from a TB scleroderma, this condition? Why it is not a TB scleroderma?
First of all, from history, we doesn't have any constitutional symptoms for this patient. Okay. And in TB, it usually presents as a cold process where there will be absent of acute inflammatory signs.
Okay. This patient has a bilateral axillary disease. So a bilateral axillary TB disease without any cervical lymph nodes and predominant symptoms is highly unlikely. Also, incidence of skin TB as such is very less, like 1 to 3%.
Any contact to TB also, right?
TB contact.
No contact history of TB.
Is there a chance to be an actinomycosis or a cat scratch disease also? Is there any information supporting that?
Actinomycosis will also present with the classical sulfur granular discharge. Patient gives no such history. That too, a disease which is occurring in a bilateral axilla with this much recurrence is very low.
Okay. You have examined the inguinal region also. If it is a
Yes.
lymphogranuloma venereum, how the presentation will be? It is also a differential diagnosis. How
It's as a painful buvo, that is a lymph node which is inflamed, and later on, if left untreated, will become a purulent, non-healing, discharging sinus.
Okay. Can you explain what is groove sign in lymphogranuloma venereum? Groove sign.
So inguinal lymph nodes, mostly horizontal, vertical groups will be enlarged. So the tunnel between this inguinal lymph nodes is called groove sign.
There will be an overlying erythema also over the lymph nodes. That is the groove sign. The organism involved in lymphogranuloma venereum.
Chlamydia trachomatis.
Chlamydia trachomatis.
What about cat scratch disease?
In organs involved in cat scratch disease.
That's all the questions we need to ask.
Treatment, we were discussing treatment.
Okay.
One more questions on treatment part.
You can continue the treatment part. Okay.
Grade 1 Hartley disease is usually started with topical management. 0.1 clindamycin or resocinol can be given. Along with this, we have to start systemic antibiotics once the patient progresses into the disease. Usually, the combined regimens of antibiotics are preferred to avoid resistance. The usually combined regimen is
That will be your last question and last answer. Thank you.
Thank you, sir.
Thank you. Thank you, sir.
Then we move to the next presentation. You can share the slides. Team Gokulam Medical College. Gokulam, can you just share your slides?
Yes, sir.
Yeah. You have 5 minutes. Make a quick presentation.
Good evening, all. I'm starting my presentation. 32-year-old female, Ananya, who is a high school teacher coming from Venyaramu. She presented with painful lump in the left breast for the past 3 months and purulent discharge from a small opening in the left breast for the past 1 month and occasional low-grade fever for the past 1 month. History of present illness. Patient was apparently asymptomatic 3 months back when she noticed a lump in her left breast, which was insidious in onset, noticed accidentally while bathing. And the lump is associated with pain, continuous, non-radiating and non-cyclical pain, and it restricts her ability to sleep on the left side due to pain. Approximately 1 month ago, she noticed the skin overlying the lump becoming intensely red, swollen, stretched, and increasingly warm, and consulted a local hospital, and IND was incision and drainage was done and given oral antibiotics. IND wound did not heal well. Since then, there has been intermittent, moderate amount of yellowish, thick, purulent discharge, and the discharge is non-foul smelling and is non-blood tinged. And there is history of intermittent fever also. No history of discharge from the nipple. No history of chronic cough, hemoptysis, evening rise of temperature, severe night sweats. No history of significant unintentional weight loss or loss of appetite. No non-contact TB history. No history of any accidental trauma, skin nodules, joint pain, and OCP conception. And no history of any other comorbidities, TB history, bronchial asthma, autoimmune diseases. And there is no breast biopsies, aspirations, or other breast surgeries. Personal history, non-vegetarian diet, normal bowel bladder habits, and there is disturbed sleep due to pain, and non-smoker and non-alcoholic. There is no relevant family history and no family history of tuberculosis or benign breast diseases. Menstrual history, menarche at 13 years, regular 3/28 day cycles with normal flow, and last menstrual period was 4/4/26, P2L2. Last childbirth was 3 years ago, exclusively breastfed for both the children 6 months and continued up to 1.5 years each. She's not currently lactating, and there has been no history of recent lactation or galactorrhea for the past 3.5 years, and not using any OCPs or hormonal devices. General condition of the patient is stable. ECOG performance score is 0 and BMI is 24, moderately built and nourished. Vitals are within stable. There is no pallor, icterus, cyanosis, clumping, or generalized lymphadenopathy or edema. And now on inspection of left breast, it is asymmetrical, appears slightly bulkier than the right. There is visible fullness over the upper outer quadrant. Skin overlying the breast, there is localized erythema. A single discharging sinus visible in the upper outer quadrant at 2 o'clock position, approximately 4 centimeters away from the areolar margin near the previous incision site. The margins of the sinus are inflamed with surrounding skin crust. A scanty, thick, yellowish, purulent discharge is noted at the opening. and nipple area complex central at the same level as that of right side, and there is no retraction, deviation, destruction, cracks or fissures, no POD orange, no visible puckering, pimpling, and right breast is normal. On palpation of left breast, there is local rise of temperature, tenderness, and a solitary, firm, tender lump is palpable at the upper outer quadrant, lying directly beneath the sinus tract, measuring 5 into 4 centimeter, and is irregular. The margins are ill-defined. The lump is fixed to the overlying skin at the site of the sinus. The lump is completely free from the underlying pectoralis muscle and is not fixed to the chest wall. No discharge is expressible from the nipple on pressing the breast quadrants, and the right breast is normal. Regional lymph node examination. Left axilla, 2 lymph nodes belonging to the central and anterior groups are palpable, measuring 1.5 into 1 centimeter, and it is firm, tender, freely mobile, and there is no matting noted. And right axilla, no palpable lymph nodes. Perabdomen is soft, no hepatomegaly, no free fluid. Respiratory system, air entry is bilaterally equal, no crepitations or rhonchi. Central nervous system is normal. Skeletal system, no focal bony tenderness over skull, spine, ribs, or the pelvis. Now the summary. Mrs. Ananya, a 32-year-old Paris, non-lactating female with a 3-month history of painful, progressively enlarging lump in the upper outer quadrant of her left breast, which was followed 1 month ago by localized acute inflammatory skin changes, undergone incision and drainage at local hospital, resulting in a persistent purulent discharging sinus associated with low-grade fever, only partially responding to oral antibiotics. On local examination, left breast is asymmetrical with visible erythema, induration, and a discharging sinus at the 2 o'clock position in the upper outer quadrant of left breast, beneath which lies a palpable 5 into 4 centimeter solitary, firm, tender, irregular lump with ill-defined margins fixed to the overlying inflamed skin, and 2 palpable, firm, tender, freely mobile, reactive lymph nodes in the central anterior group of left axilla, and the systemic examinations with the normal limits. Our provisional diagnosis, it is chronic non-lactational mastitis of the left breast with a discharging sinus. Differential diagnosis can be idiopathic granulomatous mastitis, periductal mastitis with sinus, tuberculous mastitis, and to rule out malignancy, foreign body reaction, traumatic fat necrosis, actinomycosis, and sarcoidosis.
That's a good presentation.
Thank you.
Actually, your patient presented with a painful lump in the breast, right?
Yes.
But in history of prostate illness, you said a patient noticed the swelling while bathing. What is the duration between noticing the swelling and the onset of pain?
Patient noticed that painful swelling 3 months back, which is
But in history of presenting illness, you said only patient noticed the swelling while bathing. If pain is there, that should be the presenting complaint.
Actually, patient mastitis as your first differential.
Yes. But the age of the patient, the patient is not lactating for the last 3 years. Then the patient is not a smoker.
What is the definition of non-lactational mastitis?
Chronic non-lactational mastitis is an inflammation of breast tissue, which is usually occurring in females, nulliparous females, or after 6 months of previous lactation.
Okay.
But do you not consider malignancy as your first diagnosis?
Yes. No, considering the age of the patient,
and the lymph nodes,
and there is pain in the lump, there is no discharge from the nipple,
no nipple changes,
there is no history of any nulliparity, family history is not there.
And the on clinical examination, there was a painful axillary lymph nodes and painful lump. There
and
was
it
no,
wasn't fixed.
it was all not hard or
Said favor malignancy in your diagnosis.
We didn't get
we have this.
From history, what are the points that suggestive of a benign etiology like granulomatous mastitis?
The patient is having a painful lump in the left breast.
It is a painful lump in the left breast. It is associated with a discharging sinus. There is history of incision and drainage and taking oral antibiotics. And there is minimal relief of the symptoms after taking oral antibiotics.
There is no history of weight loss in the patient. And also,
all this can happen in CA breast also.
Inflammatory carcinoma breast also.
There is painful lump which cannot be happening in carcinoma of the breast.
And ulcerated painful malignancy.
No, the ulceration actually happened following the incision and drainage.
that actually supports the diagnosis.
What are the DDs for a painful lesion in a breast?
It can be lactational mastitis, non-lactational mastitis, periductal mastitis, tuberculous mastitis. It can be actinomycosis. then traumatic incidents can happen.
Foreign
body reaction.
Fibroadenosis.
Any extra mammary conditions that mimic painful breast lumps? Sorry, painful breast lesions. Extra mammary disease that mimic painful breast.
Sarcoidosis can mimic as an extra mammary condition that causing painful.
What is the relation of diabetes and painful mastalgia?
Diabetes mastopathy is a chronic condition usually seen in patients with type 1 diabetes or type 2 diabetes, usually with uncontrolled diabetes.
What is the reason? Cause?
Usually it is an autoimmune cause, probably because of the underlying autoimmune conditions.
It causes fibrosis and hyalinization of the breast tissue. That is why it is causing chronic mastalgia. You mentioned nipple discharge in your history.
No,
There is no nipple discharge. There is discharge from the sinus.
There is no history of bloodstained nipple discharge in your history.
Yes.
Can you tell me what is the most common cause of bloodstained discharge in breast?
Papilloma.
Papilloma.
Yes, very good. Can you tell me when would you suspect malignancy when a patient complains with nipple discharge?
It can be bloody discharge from the nipple from a single duct. We can suspect malignancy.
Bloody discharge from multiple ducts is more common for CA. And
What is the 4S in relationship to nipple discharge?
4
S.
4S.
Serosanguinous.
Single, serosanguinous, spontaneous discharge. Okay.
That you mentioned tuberculosis as your differential diagnosis.
Yes.
Why isn't it first differential in a country like ours where TB is an endemic disease?
Of course, this is our country is an endemic region, but patients not having any constitutional symptoms like night sweats, evening night temperature, or any other weight loss or anything like that. And also, she is not having any history of any contact with the TB person. And on examination, there was no matted lymph nodes, and the sinus was only single. There was not a multiple, and the discharge was only serous discharge.
Okay. What are the ways in which a TB bacilli can enter the breast?
And the TB can occur in a breast mainly via osteitis of the rib or sternum, or it can enter from the contiguous internal mammary or axial lymph nodes, and very rarely it can also come a hematogenous route also from the breast.
Hematogenous spread.
Is there any hematogenous spread?
Yes, hematogenous spread also can occur, but it's very
That is also a method. Hematogenous, very rarely cracked nipples can also form a
From an underlying lymph node, there is an abscess coming out through the breast. What do you call it as? A TB abscess, which is coming from the underlying lymph node.
Cold abscess. Any
more specific term for that?
Scrofuloderma.
Manifestation of an underlying tubercular disease. Let us move on. What are the various positions of breast examination?
Patient in sitting position, arms by the side, in leaning forward position, arms raised above the head, in recumbent and arms.
What is the ideal position?
In sitting position, arms by the side of the body.
It is a semi-recumbent position which is ideally preferred in breast.
What is dial of clock method for breast examination?
We need to examine each quadrant. This is like a dial of clock from 1 o'clock, 2 o'clock.
Clockwise.
It's a clockwise manner. We need to examine each and every quadrant moving clockwise.
Okay. So, from inner to outer.
Patch of the palm, we have to examine in clockwise direction all quadrants of the breast.
Flanger aspect of the
radial examination in each dial direction.
Each dial we have to examine radially in the way.
The finger pads.
3 fingers.
You mentioned discharging sinus in your examinations. So what is a sinus?
Sinus is the blinding tract lined by granulation tissue or fibrotic tissue, usually from the underlying deep infected pocket or duct.
Necessary in a sinus tract?
What is the lining of sinus tract?
Granulation tissue. It can be granulation tissue or fibrous tissue.
Is epithelialization necessary?
Epithelialization will be there.
It is a reason for
May or may not be epithelialized.
What type of nipple retraction do you expect in a benign breast disease?
usually transverse slit-like retraction.
Why?
Fish mouth, because there will be periodical fibrosis fibrosis of the major lacteal ducts causing transverse retraction.
What is the retraction seen in malignancy?
Usually circumferential retraction.
How will you manage your case?
First, in this condition, we'll start with investigating the patient. On investigating the patient, we'll look for any rise in CRP and for the CBC. And once it is confirmed, we have to go for imaging modality. We have to look for imaging.
Breast exam together, we have a name for it.
No, proceed.
After triple assessment already explained that on history examination, we'll take the history examination and we'll clinically examine the patient, and then we'll go for the imaging modality. Here we'll start with an UST examination. UST to look for, as it is, we are suspecting an IgM in this. We'll look for any sinus tract in this patient, and we'll look for
physiological findings of chronic non-granulomatous mastitis.
Usually a hyperechoic lesion with tubular echoes. And if the patient is having a sinus tract, there will be a hyperechoic tract will be there.
In earlier stages, can you see some findings before occurring of an abscess and a sinus? There will be dermal thickening, trabeculations, increased lymphatics. What is the most common sonological mimicker of chronic granulomatous mastitis?
Hypoechoic lesion.
It can mimic breast carcinoma. Malignancy.
Can you be specific?
Yes. Lobular carcinoma.
Yes.
So you have done IND for this patient.
Yes.
What clinical finding will make you to do a true cut biopsy after doing IND?
Of course, we need to rule out malignancy in this patient. Since the patient
What clinical finding after doing IND will make you to proceed with the true cut biopsy?
If the lump doesn't resolve in size, we can do a
in the abscess, you should proceed with the true cut or coordinated biopsy.
Will you prefer to do an IND for a breast abscess?
No,
IND is not usually done.
Yeah.
What
for
is
lesions, abscess lesions less than 3
UST-guided aspiration can be done.
Repeated aspirations can be attempted.
Can you tell how you would take a true cut biopsy from a breast lump?
After local anesthesia infiltration, using number 11 blade, we are making a small incision over the lump with 14 to 16 gauge true cut biopsy needle.
So fixing the lump.
After fixing the lump,
how many tissue cores will be required?
5
How
to
many?
6 samples. We take
6.
5 to 6 samples. At least 2 to 3
What is the advantage of true cut over FNA?
Immunohistochemistry can be done.
In addition to true cut biopsy, do you want to do any other investigation in this patient?
We can also send
Microbiology?
Microbiology, AFP staining, GSM, and also gram staining can be done in this.
And we can also send the specimen
Fungal
for
culture
culturing.
should also be taken.
Fungal.
What is the common microorganism which is isolated in chronic granulomatous mastitis?
Corynebacterium, Peptostreptococcus.
Corynebacterium species. Can you tell me the substance? Propinstine, please.
How do you plan to further proceed?
We will be taking a coronary biopsy in this patient, and we will be sending it for mainly.
What histopathological finding do you expect from the core tissue biopsies?
We will be getting a non-caseating granuloma. If it is a IgM, the patient will be having non-caseating granuloma, and we can also there will be there will be multinuclear
giant cells. Foreign body giant cells can also be seen.
Will you wait for histopathology reports to start managing the patient?
No.
Only if there is a suspicion for malignancy. Otherwise, we can start with the management.
Can you make a diagnosis of chronic granulomatous disease clinically?
No, it's a diagnosis of exclusion actually, only based on histopathology examination.
What is the finding in tuberculosis in histopathology?
Caseating granulomas.
What is the difference between a gene expert and a CBNAT in TB? CBNAT is the nucleic acid amplification test. Gene expert is just a brand which developed the test. So basically, both the CBNAT and gene expert are same.
Both same.
How many lactiferous ducts are there in the breast?
15 to 20
lactiferous.
So, sometimes it can present, your chronic granulomatous mastitis can present a subareolar axis. Where does the subareolar axis usually drain as a sinus?
Usually drains near to the junction of the axilla because of the thick areola muscles. It will be not directly invading the areola. It will be at the junction.
How do you plan to treat this patient?
Plan to treat the patient, right?
This patient.
Here, as there is no response to the antibiotic, as we are confirming the diagnosis as IgM, we can start with steroids in this patient. The steroids we usually start with prednisolone, and the patient can be either.
Suppose this patient had tuberculosis, will it not cause a flare up? So first we have to rule out
After
tuberculosis.
ruling outing.
Continue.
Hence, we confirm the diagnosis as IgM. What I said. Hence, we can start with steroids as the first line of management. Steroid, we start with prednisolone. Once we start with prednisolone, there can be steroid responders and there can be non-steroid responders. If there is any non-steroid responders, we can go for second-line therapy, that is methotrexate.
Is there any role of antibiotics with the steroids?
Or will you straight away start with steroids?
Only steroids or addition will you give any antibiotics to this patient?
Antibiotics also can be started along with
Because
this.
if
Which antibiotic?
Doxycycline or clarithromycin can be given against the Corynebacterium protestant.
Any other additions?
At the anaerobic infection control, metronidazole can be given.
Rifampicin is also
Rifampicin also can be started.
So, if you isolate Corynebacterium propin steady, will you change this management?
Of course, we can stop the steroids and start the patient
Start
on
the patient on antibiotics.
doxycycline or clarithromycin.
Doxycycline.
Your last question.
Clarithromycin can be given to this patient.
surgical management?
Role of surgical management.
Surgical management is usually done if it is a chronic recurrent mastitis with mammoid fistula or any.
What surgery will you do?
We will do a Hadfield's procedure for this patient.
Will you do a Hadfield procedure?
No, for this
Thank
patient.
you very much.
For this patient, it will be a wide local efficient.
They comment.
Thank you very much. We'll have to move to the
Thank you, sir.
Thank you, sir.
Thank you.
Thank you both, Gokulam and GMC Kottayam. You can stay back while I call upon the next two teams. Who are the next two teams?
Sir, I think we need some suggestions from the judges after each match, right?
Sir, we will finish all these things. Otherwise, we'll be running short of time.
Next is Alleppey versus Kollam, sir. Alleppey.
TDMC Alleppey versus
Travancore Medical College, Kollam.
is Travancore Medical College? Yeah, it's available. Okay. Can TDMC Alleppey make the first presentation? TDMC Alleppey, can you make the first presentation? Come online. We're already 15 minutes late. TDMC Alleppey. Dr. Preeta, can you come on? TDMC, can you come online? Please come online.
They are online. I think there are some problem with camera. I think they are talking. Yeah.
Okay. Okay. So you make the first presentation, share the slides. On the either on the top toolbar or the lower toolbar, can you just see a green light with share button? share, click there.
Okay, sir. വേറെ വിൻഡോ അല്ലേ?
നിങ്ങളുടെ സ്ലൈഡ് ഓപ്പൺ ആണോ? It's coming.
Yes, sir.
Yeah. Go to the slideshow mode. Slideshow പോയാൽ അറിയാമോ?
ചിലപ്പോ സ്ലൈഡ് കാണാം.
താഴെ. Go to the right. Go to the right.
സർ നമ്മളെ കാണാമോ?
നിങ്ങളെ കാണാൻ നിങ്ങളുടെ slide show മോഡിൽ പോകണം.
സ്ലൈഡ് ഷോ മോഡിൽ പോകാം.
Can you go? Your
slide
cursor,
show.
go down to the right side. Just, there. Click there. Yeah, that's right. Go on.
Sir,
You
can we
lost
start?
4 minutes actually.
Can we start?
Go on.
So we are TTMC Alapura. We are here to start the case presentation.
Good evening. My patient is a 35-year-old male, a resident of Punnapra, fisherman by occupation, presented with a swelling in the left upper back for last 1 year. History of presenting illness. Patient was apparently normal 1 year back when his wife noticed a swelling in left upper back region, but patient ignored the swelling. Recently, his relatives insisted on seeking medical advice. Hence, he presented with complaints of swelling in the left upper back in our OPD, which was approximately the size of a lemon and was not shown any apparent increase in size since then. There is no history of any trauma, no history of any associated pain or restriction of movements, no history of any other swelling elsewhere in the body, no history of any skin changes or discharge, no history of any similar or recurrent swellings in the past, no history of associated fever or weight loss. Past medical history, nothing relevant in his medical history, and no significant surgical history in the past. The personal history is consuming mixed diet with no non-food or drug allergy, sleep and appetite normal, bowel and bladder habits regular. He is a non-alcoholic and non-smoker, no history of any tobacco chewing. Family history, there is nothing significant in his family history.
Coming on to examination, he was conscious, cooperative, and oriented to time, place, and person, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. He was febrile with stable vitals. Coming on to the local examination, on inspection, there was a 4 into 3 centimeter ovoid swelling in the left scapular region, which was 5 centimeter away from midline, 2 centimeter above the spinous process of scapula. It had an even surface and well-defined border. The skin over the swelling was normal. There was no scar, sinus, or venous engorgement. On palpation, there is no local rise of temperature. The swelling was non-tender. There was a 4 into 3 centimeter ovoid swelling in the left scapular region, which was 5 centimeter away from the midline and 2 centimeter above the spinous process of scapula. The surface was lobulated. All borders were palpable. The swelling was on the subcutaneous plane and it was not fixed to the skin or underlying structures. The slip sign was positive. The swelling was soft in consistency and there was no molding or pitting on pressure. The swelling was non-fluctuant, non-compressible, and non-pulsatile. Percussion and auscultation are irrelevant in this case. So to summarize, we have a 35-year-old fisherman, a non-alcoholic and non-smoker with no known comorbidities, presenting to the surgical OPD with a swelling over the left upper back for last 1 year, which is painless, non-progressive, with no history of trauma, restriction of movements, no skin changes, skin discharge, or similar swellings elsewhere. There are also no systemic symptoms such as fever or weight loss. Local examination revealed a single 4 to 3 centimeter ovoid subcutaneous soft swelling in the left scapular region, located 5 centimeter from the midline and 2 centimeter above the scapular spine. It had a lobulated surface with well-defined border. The swelling was freely mobile and not fixed to skin and underlying structures, with positive slip sign. From the case summary, we came to a provisional diagnosis of a subcutaneous lipoma of scapular region.
The Kollam team can ask the questions.
What are the points which make you diagnosis with this? What are the points which leads to the diagnosis of this lipoma?
Because
Can you come closer and speak loudly?
Sir, what are the points? What were the points that you considered to be in favor of the diagnosis of it being a lipoma?
Because in our from our history and examination, there's a history of a slow growing painless tumor which was soft in consistency with non-tender and mobile, and also it is on the with a positive slip sign, and also it is freely mobile, giving the history of a subcutaneous, giving more towards subcutaneous swelling. Also the location is also most favoring for the site of lipoma, because it is a universal tumor.
Why it is called as a universal tumor?
Because it can be,
it can occur anywhere in the body, like subcutaneous and subfacial, parosteal.
The swelling can occur anywhere in the body where there is adipocytes.
In your history, you mentioned that there was no restriction of mobility with respect to the swelling. What sort of restriction are you expecting in a case where the swelling is in the upper back?
So in the upper back region, if there is any muscle infiltration, so there is a restriction of movement of the muscles of that region, which is shoulder movements will be restricted if there is muscle infiltration.
So what are the other types of lipoma you expect?
Sorry?
What are the other types of lipoma?
So lipoma can be classified based on the site, based on the component, or based on encapsulation. Based on the site, lipoma can be in the subcutaneous, intramuscular, subfacial, subserosal, submucosal, intrasynovial, intraarticular, or even intraglandular. Based on the components, lipoma can be angiolipoma, nevolipoma, neurolipoma, myolipoma, fibrolipoma, and based on encapsulation, there is encapsulated lipoma, diffuse lipoma, multiple lipomatosis.
Okay. So in your case, it is actually painless in nature. Okay.
Yes.
Painless in nature. So can lipoma be painful?
Yeah.
Yes, lipoma
Yes.
can be painful.
In
In case
any
of
condition?
postmenopausal that is in case in Dercum's disease, in the postmenopausal woman, the lipomas can be painful. That is adiposis dolorosa.
Or in case of
neurolipoma,
No.
nerve, when the lipoma compresses the nerve, then it can cause pain. It is from neurolipoma also. All these cases, it is painful. And also, if it is malignant transformation like
It's not.
if it is a malignant lipoma which is undergoing rapid increase, liposarcoma which is undergoing rapid increase in size, it can cause pain.
Lipoma can be turned into malignant.
No, lipoma doesn't undergo malignant transformation. If it was malignancy, it would have been de novo liposarcoma.
That would be the most common site of such a occurrence in the body.
What?
In case of liposarcoma, where would be the most? What would be the most common site?
Retroperitoneal thigh.
So you mentioned that you had tested for the fixity over the skin as well as towards the deeper structures. How did you test for any fixity towards the deeper structures? What did you ask the patient to do to make sure it wasn't attached to the deeper structure? What movement did you ask the patient to do?
Okay, so the first we look for the mobility of the swelling. First, we'll for ruling out deeper structures, we first try to move the swelling in all direction, that is in the perpendicular direction. And if the swelling is freely mobile, it indicates that it is not fixed to the underlying structure. We also ask the patient to.
You have just made sure that the swelling is freely mobile. Would you rule out fixity to the underlying structures? That is what we have mentioned, right? So you have to make sure that the underlying muscles are fixed so that you rule out fixity. No. So how did you make sure that the lipoma was not fixed to the underlying structure? What was the movement that you asked the patient to do? In this case, it's a left upper. What did you ask the patient?
In this case, the since the swelling is in the upper scapular region, we ask the patient to
Ask the patient to abduct the shoulder against the wrist, and we moves the swelling. If it moves, it doesn't.
Would you look for fixity in that abduction movement?
When the muscle become taut, if it is fixed, fixed
At
means.
what point in abduction does the muscle become taut?
Sorry?
At what point of abduction does that muscle become taut? When you're looking
0
at
to 15 degree of abduction of shoulder.
Excuse
It's
me?
done by supraspinal. First to 15 degree.
0 to 15 degree of abduction.
So you said that it is soft in consistency, right? And can lipoma be always be soft in consistency?
No, subcutaneous lipomas are mostly soft. When it is deeper, like subfacial and intramuscular, it may be firmer.
Sperm also. Depends on the depth and the constituents. And if it is mixed with fibrous tissues, if it is fibrolipoma, neurolipoma, etc., it may not be soft always.
Okay. So sometimes if I ask you, in your case, it is hard in consistency, and also in your case it is around 4 to 5 centimeter, right? Approximately 5 centimeter.
4
size.
to 3.
No, approximately 4 centimeter.
And suppose if it is a 4 to 5 centimeter in more than 5 centimeter, and it is hard in consistency, and if it is fixed, okay, and what will be your diagnosis?
You will suspect for soft tissue
sarcoma.
Liposarcoma. And we
Genetic relation for lipoma?
Genetic
Any
relations.
genetic relations?
It is. There are many familial associations are there. Familial multiple lipomatosis, Cowden syndrome. It can be associated with Proteus syndrome and Benign syndrome, Gardner syndrome. These are the usual associations.
In this particular case, how would you proceed? What would you do next? You have your possible diagnosis. What is your next step in management?
Since from our history and clinical examination, we suspect a benign lesion, we would directly go for excision of the swelling. Excision biopsy of the swelling.
it's like clinical.
It's a clinical diagnosis. So in this case, the patient says, okay, the doctor has counseled me that the swelling is benign and I don't need it to be excised at this point. At a later date, if the swelling is increasing in size, what sort of investigations would you undertake? It's only been 1 year. The swelling is likely to be present. If he decides not to get rid of it, it's likely to be present over a long period of time. In case there is some sort of size change over that period of time, what investigation would you do? What sort of investigations would you ask the patient to undergo in order to rule out any sort of malignant change or, in fact, any de novo malignancy arising in the same patient?
We will proceed with the USG first for any non-adipose non-lipomatous components, and for most of the soft tissue sarcoma, we will do MRI for local area. Then MRI confirms.
What are you expecting on the ultrasound?
For lipoma, it's a homogeneous hyperechoic compressible mass. When it's a liposarcoma, it may have non-adiposite components with calcifications and the heterogeneous
changes.
Any blood investigation that you would like to do?
Lipid profile.
Why?
Significant question, bro.
Blood investigation.
Any blood investigation that you would like to proceed with?
Anything significant?
Any cytogenetic studies that you would like to do? Any sort of
Cytogenetic studies.
Cytogenic biopsy.
Patent mutations.
Biopsy.
Go for it. Yes.
Sorry.
Fine. So, what sort of procedure would you do for this patient in case he wants to get it excised?
What kind of procedure?
What is the procedure you would proceed with in case the patient wants to get rid of it? So what
Yeah,
do
so we go for an excision where we give the local anesthesia, and then we make an linear incision along the Langer's line, and then after reaching the capsular level, we dissect along the capsule and extrude the swelling, and then close the defect using non-absorbable and skin using absorbable sutures.
How would you differentiate between the
Using
normal
non-absorbable, sorry. Sorry?
How would you differentiate between the normal adipose tissue located there and the lipoma that you're trying to excise?
After subcutaneous tissue, we'll be able to see a capsulated, smooth, lobulated swelling.
Not necessarily. So how do you differentiate the adipose tissue per se from the lipoma that you're trying to excise? What would be the change in features that you would notice of the adipose tissue that's located in the lipoma associated with respect to the surrounding fat that would be present in the upper back normally? Grossly.
There is a smooth
lobulations,
presence of lobulations.
Yeah, the normal fat is also lobulated. What would be the difference?
There will be capsule and septations within this lipoma that is usually not present in the normal fat.
Adipose tissue become bigger in size than normal.
Yeah, the lobules in the lipoma tends to be bigger in size compared to the surrounding normal.
Okay, then what are the surgical indications of removing lipomas?
What are the surgical indications?
First, patient preference, then cosmetic cause, then rapid growing swellings, more than 5 centimeter swelling, clinical.
If the swelling is not soft, any firm or
suspicious for malignancy.
Your last question.
Your swelling is in the interscapular region, no?
Yes.
In
the upper left upper scapula.
Okay. How will you differentiate it from hibernoma and lipoma? How will you prove it's not a hibernoma?
Hibernoma is classically pediatric fat tissue and most common in pediatric age, and its location is interscapular, axial, and mediastinal.
So basically,
And it's brown fat actually. We are dealing with white, yellowish.
which is more vascular, hibernoma or lipoma?
Can TMC make the next presentation? Since we are running short of time, please make the next presentation. You can share your slides.
Thank you.
TMC?
Yes, sir, one man.
You have gone out of the frame.
Yes, sir, one man, sir.
You know, there is a green button which is either on in the toolbar. Say share.
Yes, sir.
Yeah, go ahead.
Sir, are you able to see the screen?
Go to the slideshow mode. Okay, go ahead.
Are you able to see, sir?
Yeah. Go ahead.
So we are pursuing a case of Shandanu. He's a 48-year-old male who is an office worker working at Kolam. So basically, he presented with complaints of a swelling over the right side of his scalp, which has been present for the past 2 years. And it has been associated with pain over the swelling for the past 4 days. And he has noticed discharge from the swelling for the past 2 days. So the history of present illness. So the patient noticed the swelling over the right parietal scalp 2 years ago, which was initially the size of a peanut, and it has gradually increased to reach the present size. And for the past 4 days, it has been associated with pain, which is throbbing in nature. And There has been a discharge from the previously located swelling for the past 2 days, which is being described as being cheesy and foul smelling. There is no history of any sort of trauma over the affected region, no history of associated fever or similar swellings elsewhere in the body. As for the past history, he's a known case of type 2 diabetes mellitus for the past 3 years, and he's on treatment for the same. There is no history of hypertension, dyslipidemia, tuberculosis, jaundice, seizures, or any thyroid disease. As for the personal history, he takes a mixed diet. His sleep is adequate. Bowel and bladder habits have been normal. He has a history of occasional alcohol intake, and he's an occasional smoker. As for the family history, there is an incidence of diabetes and hypertension in the patient's parents. There are no recorded comorbidities in the patient's siblings, and there is no history of any sort of similar swelling in the family. On general examination, the patient was found to be conscious oriented and afebrile. His BP was measured as 140 over 80 millimeters of mercury. Pulse was found to be 78, and saturation was 98% on room air. There was no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy, and the patient was moderately built and nourished. On local examination, on inspection, a single swelling was found over the right parietal scalp. It was measuring approximately 2 into 2 centimeters and was found to be round in shape. The surface appeared smooth with well-defined margins. The skin over the swelling and the surrounding region was found to be erythematous, and there was white discharge that was being extruded from the summit, and the swelling was non-pulsatile. On palpation, the local temperature was found to be raised, and tender was present on palpation. On palpation, the swelling was also soft and it was fluctuant. The skin over the swelling was non-pinchable, and the swelling was found to move along with the movement of the skin, and it was found to be mobile in all directions. It was non-reducible and non-compressible. Transillumination of the swelling was negative, and on regional examination, there were a few mobile lymph nodes that were palpable in the right occipital region, which were found to be tender on palpation. On systemic examination, cardiovascular system, S1 and S2 were heard, no murmurs. There was no focal neurological test on the cranial nervous system examination, and upper abdomen was soft. The bowel sounds were heard, and there was no palpable organomegaly. Chest was clear, and air entry was bilaterally equal. It was, we went with the provisional diagnosis of an infected epidermal cyst over the right parietal scalp. So to summarize, it's a 48-year-old male.
Okay, that's okay. That's okay. We have short cases. Just go ahead with the questions. The opposite section. TDMC.
Why do you say that it's a epidermal cyst?
First of all, the site, the scalp, and the indentation sign was positive.
Can you be a little loud and also need to come into the frame? We don't want any other support from anybody. Go ahead.
First of all, the site of the cyst is in the scalp. It's one of the most common site of the sebaceous cyst. And the second one is indentation. It was positive.
Then there was the exclusion of the foul smelling CC material from the summit, which is again suggestive of tuberculosis or sebaceous cyst, that is sebum being excluded out. That has been
What are the other probable differential diagnosis?
Dermoid cyst, it can be dermoid cyst, or any pulsatile bone swellings, which can be primary or secondary.
I think it could be university, but it could be lipoma.
Sorry, please be
It
louder.
could be a lipoma of the scalp also. A possible differential diagnosis as a lipoma of the scalp, but it's unlikely to get infected, and it's unlikely to have a discharge from the thumb.
Okay.
It's not audible. Okay, next question. What are the common location of epidermoid cyst?
The common is seen on the scalp region, back, and or the hair. Can be seen where are the hair follicles are present mostly seen.
The scalp, the beard region, the
Neck region, neck, shoulders, back.
Can you little bit louder? Can you?
We can hear you actually.
Scalp, scrotum, neck, shoulders, back, wherever the sebaceous glands present, it can be.
hairy areas are more common.
What are the sites where epidermoid cysts are not usually found?
The palms,
Not found.
toes,
Sorry.
Palms and foot.
Why it is called epidermal cyst?
Why it is called epidermal cyst?
Because from there is an epidermal inclusion it has been occurring. From the theory itself, it shows that there is a keratin plug formation and the invagination of the epidermal cells are occurring. So there is a blockage, and it's so because of the proliferation of epidermal cells, then it is called epidermal inclusion system.
Then it's truly line by two stratified squamous epithelium.
Stratified squamous epithelium. That is very squamous. Okay.
Other names of epidermal cyst?
Tricholemous cyst. When it's in the scalp, we can call it as when.
Sorry.
If it is in the scalp of the sebaceous cyst, we can call it as when. W-E-N. When.
So sebaceous cyst, epidermoid cyst, epidermal inclusion cyst, epidermoid cyst. These are the terms.
What are the complications you accept in this case?
It can be infected.
Rupture.
Sebaceous bone can be
Sebaceous bone, peculiar tumor, sebaceous bone, and sometimes there is a chance of rare malignant transformation, which can, such as squamous cell carcinoma. It's actually rare.
Okay. What is the significance of age in this case?
Actually, there is no. It is in mostly seen in people,
middle age. Mostly seen in the middle age.
30 to 50 years old is the usually is gap in which it occurs, but there is no clear-cut rule that says that it cannot occur elsewhere, because we commonly see patients that come in such areas also in adolescents, especially wherever there is excessive sweating and relatively poor hygiene. Also, we tend to see this case, but the described common age group is 30 to 50.
So if the sebaceous cyst is found in a pre-pubertal age group, what will you look for?
What specifically, or as part of the diagnosis?
Specifically.
How will you proceed the case? If you see a multiple epidermoid cyst in a young
Suppose there are abnormal numband site in a pre-pubertal age group.
Okay, the diagnosis should be clear, because if we see a punctum and there are signs of indentation or molding things are seen, it is actually clear cut that it is a case of a sebaceous cyst. Then we directly go for excision. Then further.
All the
So mainly, what we intended was a multiple number of sebaceous cysts in the pre-pubertal age group in abnormal locations will indicate towards some syndromic relations.
You have to. How will you
Okay.
assess it?
And how will you consider such cases?
What is the significance of
family history in this case?
Association with Garden syndrome.
Yeah, intestinal polyposis maybe.
Any syndrome? Name of any syndrome?
Excuse me?
Any syndromic association of sebaceous cyst?
Gardner syndrome.
Yes, Gardner syndrome.
Gaudet syndrome also is there.
When you see such cases like multiple epidermal cyst in young age, you have to work up for Gardner syndrome. Like you proceed with colonoscopy and biopsy if any polyps. That's important.
Suppose you're suspecting Gardner syndrome, you have to go for a proper family history, whether there is a familial adenosis polyposis, familial adenosis polyposis history, colonoscopy, then retinal examination, etc. That is the significance. Okay.
What is the significance of drug history in this case?
Is there any
drugs causing or related to sebaceous epidermal cyst?
Do you know any drugs causing side effects of causing?
There could be some vitamin.
Vitamin E.
No.
Retinoic acid.
Retinoids that can cause acne in young.
That's acne.
Retinoic acid.
No, it is said that BRAF inhibitors like dabrafenib, vemurafenib, or cyclosporin, tacrolimus, all these are associated with sebaceous cyst. It's also said like that. Okay. So you said that indentation was positive.
Last minute for you.
What is sign of molding?
The pressure is applied.
Basically, once the pressure is applied over the swelling, there's a change in shape of the swelling with the size of the swelling remaining the same, and the change in shape remains persistent even on removing the pressure over the swelling.
Other swelling which shows molding positive, other than sebaceous cyst?
Sebaceous cyst, dermoid cyst, then even hard fecal matter in the second column, the left iliac fossa.
Fecal loading.
What is Paget's test?
In small sebaceous, we use one finger to elicit the slip sign. We will press over the summit of the swelling.
Fluctuation will be felt as
Sorry? So, in case of small swelling where two fingers cannot be accommodated, when we press in the center of the swelling, the center will be softer than the periphery. If the center is firmer than the periphery, it is not cystic. That is the significance. Okay. Have
Thank
any
you.
illustration in
Last
the
question.
Bailey?
Question.
There is a famous illustration in the first page of Bailey.
Yes.
Can you name it? What is that name?
sebaceous bone, but
I
not
agree,
sure
it is not
about the
Bailey as
ladies. We don't know the ladies.
How will you
Sorry?
proceed? How
It
will
is
you
woman, widow of Demanje.
how will you
Okay. How will you proceed in this
case?
case?
Oh, sorry, we have to stop. Thank you very much. We'll have to move to the next set of layer of teams.
Thank you, sir.
Good presentation. Congratulations to both of you. We move to the next set of examination, which will be between MES Medical College and KMCT. MES at Peridhalmanna and KMCT Calicut. MES, can you come online? MES? KMCT, can you come closer? Is MES here?
MES Dr. Vishnu was supposed to be there. Okay.
It has come. MES? Yeah, here they have come. Who wants to make the presentation? MES, can you go ahead with the presentation? Share your slides. KMCT, can you come closer? The central two people should come closer. In MES, we can't see the third one, fourth person. The one behind, yeah. Yes, that's right. Go ahead. MES, make the presentation, please. Go to the slideshow. Please go ahead, proceeding. You're not audible. You're not audible. You are not audible. Can you increase the microphone volume of yours? Can you say hello to me? No, nobody can hear. Can KMCT hear?
Hello. No, sir.
Audio
കേൾക്കുന്നുണ്ട്.
spatial audio ആണോ?
You're beginning to come in. You
Okay,
can be
doctor,
heard
no
very lightly. No. Say hello to me again. No. There is a speaker kind of an icon which is there in your right or left toolbar. Sorry, top or bottom toolbar. Can you see that? Put your cursor there. Click on it. There will be a blue vertical button which is coming in. Where is that round seen now? Increase that, increase the volume. No. Okay. Are the next teams ready? Meanwhile, you can switch on to another computer. You can switch on to the next computer and see whether that's working, if you have the computer. Madhu, is there a next team?
So next team is Trivandrum, Dr. Samuel and Kolanjiri, Dr. John. I think I can see both teams.
No, MOIC is there.
GMC Trivandrum is also there, sir. That orange icon.
Huh?
GMC Trivandrum is there, sir.
Okay. Let's take them up and let these people, kind of try to do something. We'll give them a 5-minute chance. They have already lost 5 minutes. Shall we take up if KMCT agrees to that and MES agrees to that? We'll take the next group and then we'll come back to you. Is that okay?
Okay, sir.
Okay, can GMC come online, please? GMC?
Videos. Sandeep, come back.
GMC Trivandrum, can 4 of you come together? Say hello to me.
Good evening, sir.
Good evening.
Am
And
I audible?
the next team is MOSC. Can you come online, please? MOSC? All 4. We need to see all 4 of you. Come online. See, this is a very tight match. We have been telling you that this is a tight match. Time is precious. Can MOSC please come online? MOSC, can you just switch on your video? Hello?
Are they present today?
No, they should actually rehearse all these things.
They are present, sir. We can see the icon of the MOSC. Okay. Yeah, fine. That is MES.
That is MES. You're not audible, MES.
Yeah, most
Yeah,
custom.
Sir,
MOSC,
are we
can you
audible,
just
sir?
say hello to me?
Hello, sir.
Yes, sir.
Okay, fine. GMC Trivandrum, you make the presentation.
Okay, sir. Just a moment.
Sir, are we audible?
Yeah.
Yeah, you're audible.
Okay, sir.
Go to the slideshow. Okay, go ahead.
Is this okay? Yes.
Yes, go ahead.
Good evening, everyone. Myself, Dr. Samuel, my teammates, Dr. Anana, Dr. Priyamada, and Dr. Sandeep, representing Trivandrum Medical College Department of Surgery. Starting with the presentation, a 54-year-old male, resident of Vaidakad, Thiruvananthapuram, He's a shopkeeper by profession. He came to us with pain and swelling around the anal opening for the past 1 day. He had severe pain around the anal opening for the past 1 day, which was acute in onset, constant in nature, and with increasing severity. The pain was aggravated on sitting. There was also a history of associated swelling in the region, which was extremely painful on touch. There was history of straining for stools, but there was no history of abdominal pain, itching, bleeding PR, fever, or pus discharge per rectum. There was no history of loss of weight or appetite, no history of similar episodes in the past, and there was no history of trauma to the region. Coming to the past history, there was history suggestive of hemorrhoids, which was managed conservatively 1 year back. There's history of diabetes mellitus on oral hypoglycemic agents. There's no history of CLD, no history of surgeries in the past, and no known drug allergies. He had history of recurrent episodes of constipation for which he was on laxatives. He follows a non-vegetarian diet. He has normal sleep and appetite, and occasionally he consumes alcohol. There was no similar illness in the family. On general examination, he is well built and nourished with a BMI of 31 kilograms per meter square. There's no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. He was conscious and oriented with a pulse rate of 80 per minute, BP of 140/90, respiratory rate of 18 per minute, and he was afebrile at the time of examination. On inspection, a 3 into 2 centimeter ovoid swelling with a bluish hue at the anal verge at 9 o'clock position was noted. The swelling was tense and tender on palpation. Hence, further digital rectal examination and proctoscopy were not done. There was no other visible swellings, scars, or sinuses in the area, and there was no enlarged inguinal lymph nodes bilaterally. On examination of abdomen, it was soft, non-tender, there was no distension or organomegaly, and normal bowel sounds were heard. And all other systems were within normal limits. So the case summary is a 54-year-old male, a known diabetic, presented with acute severe pain and swelling in the anal opening for the past 1 day. He gives history of straining for stools with no history of fever, bleeding PR, pus discharge, or trauma. On examination, it was a 3 into 2 centimeter ovoid, tense, tender swelling with a bluish hue at the anal verge at 9 o'clock position. So our provisional diagnosis is thrombosed external hemorrhoids.
Thank you. The opposite team can ask questions. MIC, please ask questions. Your time is valuable.
Yes, sir.
Please ask questions.
Do you need any other investigations to confirm your diagnosis?
Sorry, could you come again?
Do you need further evaluation to confirm your diagnosis?
This is a case since we have gone with the diagnosis of thrombosed external hemorrhoids. It is purely majority of the cases, it is just a clinical diagnosis. And also, if the patient accommodates, in our case, the patient was not accommodative, the patient had severe pain. So we didn't go for a digital rectal examination. We entirely focused on clinical examination and just the inspection of the perianal region.
What could be the possible differentials associated?
In our case, the differentials that we considered included a chronic anal fissure with a central tag. It could also be a prolapsed internal hemorrhoids and also an acute anal fissure as well as perianal abscess.
How can you differentiate it from a prolapsed internal hemorrhoids?
Yep. A prolapsed internal hemorrhoid usually has a mucosal covering over it, as well as a prolapsed internal hemorrhoid is usually painless, as the internal hemorrhoid usually arises above the dentate line. So it is usually a painless swelling.
Can a thrombosed external hemorrhoid occur without a prior history of hemorrhoid disease?
Yes, it can occur without a prior history of hemorrhoidal disease. In fact, most often it is caused by a sudden straining episode that is going to cause bleeding within the external vascular plexus within the tight space. That is going to give rise to the tense and this painful nature of the swelling.
How would you differentiate it from a melanoma, malignant melanoma?
So history-wise, we are going to have like malignant melanoma is not going to have an acute onset. It's going to be there for a while. The patient it's not going to be very painful, and these are going to be raised plaques that are going to be more amenable to examination, and also all the ABCD features of melanoma are also going to be there.
How would you confirm the diagnosis? Like, what is the investigation? What else would you do?
Like to differentiate between a melanoma and a thrombostectomy. I think within a clinical, like it can be differentiated with clinical examination, because thrombosed external piles by examination, it's going to be there.
Beyond clinical examination, what other?
Then we'll take a biopsy if at all there is going to be any such doubt.
Okay.
You have mentioned about CLD. In the history of CLD was mentioned. Why was it mentioned? What is the rationale?
In CLD, actually, we can get bleeding per rectum, and there is a cause of rectal varices which can produce with, present with pain also in this patient.
If it is rectal varices, then how would
the management
will differ?
Sorry?
How would the
Because
management
of-
differ if it is caused due to rectal varices due to CLD, like portal hypertension?
Yeah, so the rectal varices are basically caused because of the portosystemic hypertension, right? So they are going to be not only limited to the just above the dentate line where the AV cushions are going to be there. They are going to extend upwards. So in those cases, it's more important to control the portal hypertension than to go for any kind of surgical management. So that becomes more important. Surgery will not be part of management for that at all, unless it's a very acutely severe case. Even in that case, we'll go for conservative parking and other things.
What is the significance of examination of lymph nodes in this patient? Do you expect any lymphadenopathy in this patient? You told no lymphadenopathy.
In case of an external thrombosed hemorrhoid, if it's in case of it is infected, we can get an inguinal lymphadenopathy that we have to rule out. Or in case of any anal malignancy, in that case also we can get an inguinal lymphadenopathy.
Yes.
Why do we get a bluish hue in an external thrombosed hemorrhoid?
It's because these enlarged dilated veins are present subcutaneously. That's why it's giving a bluish hue on examination.
Would you attempt colonoscopy in this patient?
In this setting, in our presentation, since the patient presented with a severe episode of pain, colonoscopy is not advised. But if we are suspecting any further investigations that need to be done, once the initial acute phase is settled, we'll definitely go for a colonoscopy.
How would you differentiate this from a case of rectal prolapse?
A rectal prolapse will be circumferential. Here it is just, it is a localized pile mass at a 9 o'clock position. So that is a main differentiating factor in this clinical scenario.
How will you manage this case? What is the further management part?
So our patient presented within 1 day. So we can go for evacuation of the clot. If the patient presents later, then we can go for conservative management and allow the clot to extrude on its own. We can even do that if the patient is refusing any surgical procedure. However, with the severity of pain, usually they agree for an evacuation of the clot.
Would you go for an
Although,
IND or an excision?
what?
Which would be more preferred, IND or an excision?
Actually, recent evidence has come up where excision is also equally advised, where the length of stay and the healing rates have all become faster with an excision. However, excision has its own problems, like the patient needs to be advised good anal hygiene and all of those things, because there's always a risk for anal sepsis in those cases. So we need to weigh the pros and cons and proceed accordingly. But yes, excision has come up with recent evidence as an equally good treatment modality with faster healing rates and better relief of pain as well.
In terms of recurrence, which is better, IND or excision?
Excision with current evidence.
Do you suture after an excision? Do you suture?
Would you
Suture
close the
after
wound after excision?
Would you close the wound after an excision?
You can leave it open, no need. No need to
Keep it
suture
open.
this.
What if it was in prolapsed internal hemorrhoids? Management.
For the management.
Management part.
How would the management differ?
So, in case of a prolapsed internal hemorrhoids, first thing is, so in any of these anal rectal diseases, first to address the inciting factor. There is no point in going for a surgery or any such thing without addressing the inciting factor, which would be constipation. So first, I will be completely evaluating that. Then, if after addressing that, again, conservative management comes with laxatives, stool softeners, dietary modifications, and all of those, which are going to address the inciting factor. After the patient's compliance has been addressed with that, then I can go for surgical management. I can, and there is a lot of it's like a basket approach, because there are a lot of modalities that are available currently. And for a prolapsed hemorrhoid, which is a grade 4, mostly if it's an uncomplicated, we can go for an elective surgery. So many options are available. We can go for if it's a pure internal hemorrhoid, then we can go for a stapler hemorrhoid. It's an internal external, then we have to go for one of the excisional hemorrhoidectomies. Again, there's also newer modalities like hemorrhoidal artery ligation, etc.
Okay, why is thrombectomy not preferred? Why is thrombectomy not preferred?
Excuse me? Can you come again? Can you come again?
Why is thrombectomy not preferred as a line of management routinely?
We are not sure.
Yeah, because it can cause incomplete evacuation and lead to recurrence.
What are the complications that this patient can develop if left untreated? Why do we do a surgery in this patient?
See, if left untreated, the most common complication it can lead into, it can develop a gangrene or it can go into an ulceration. These are the two main complications that we expect in case of a thrombosed external hemorrhoids. So we mainly anticipate both the gangrenous change as well as an ulceration.
Is there a chance it can lead to Fournier's gangrene?
Unlikely, it can, depending upon the patient profile. In our case, he's a known case of type 2 diabetes mellitus. Even though the incidence of Fournier's gangrene with a thrombosed external hemorrhoid is very rare, but it has been reported.
If this patient
Thank you very much. Can the next team come in with the presentation?
Okay.
MOIC, can you just share your slides?
That's great.
Great. Okay. You're muted, MOIC. Please unmute and make the presentation. No, your voice is muted. Please unmute your voice.
Okay. Can you hear now, sir?
Is it audible, sir?
Yes.
Presenting the case of Joel Binu, a 28-year-old male patient who was a software engineer by occupation and residing in Muatupura. He came with chief complaints of pain during defecation since 3 months, occasional bleeding per rectum since 3 months, constipation since 6 months. History of presenting illness. The patient was apparently well 6 months back, and after which he developed constipation characterized by passage of hard stools and excessive straining during defecation. About 3 months ago, he started experiencing severe pain during defecation, which he describes as sharp, cutting, tearing type of pain, maximal during the passage of stools, and persist for 30 minutes to 1 hour post defecation. The history of patient not passing stools due to the fear of pain was present. Patient also gave history of bleeding per rectum, which was on and off and associated with passage of stools. It was bright red in color, small quantity. It was seen streaking over the stool and not mixed with stools. He also gives history of burning sensation in the anal region after defecation. There was also occasional itching. There is no history of mass per rectum, pus discharge, mucus discharge, altered bowel habits, or abdominal pain. No history of chronic diarrhea, weight loss, or fever, night sweats. There is no high-risk sexual behavior or trauma. There is no history of any immunocompromised states. Past history, no previous similar episodes in the past, no history of diabetes mellitus, hypertension, no prior anorectal surgeries. Drug history, he occasionally used over-the-counter laxatives for the past 3 months, and there is no history of any anticoagulant use. Coming to personal history, patient consumes a non-vegetarian diet, and there is a history of decreased fluid intake. His bowel and bowel habits are irregular, and passing hard stools and the history of straining was present. Sleep and appetite was normal. Coming to addiction, there is no history of smoking. He is having occasional alcohol use and leads a sedentary life. Coming to family history, no similar complaints in family, no history
You
of
have just 1 minute for presentation. You have just 1 minute for your presentation.
Summarizing the history, a 28-year-old male with history of chronic constipation since 6 months, presenting with severe pain during defecation and bright red bleeding per rectum since 3 months with history of pain persisting after defecation. Coming to clinical examination, after taking informed consent, patient was examined in a well-lit room with adequate exposure. General examination, patient is moderately built and nourished. He is conscious, oriented, and cooperative. General physical signs, no pallor-icterus cyanosis,
This does not contribute. This does not contribute anything to your. Quickly go because we are running short of time.
Local examination, rectal examination, inspection. A linear ulcer was seen in the anal canal at posterior midline 6 o'clock position. There was a single longitudinal tear at 6 o'clock of size 1 into 0.5 centimeter with indurated edges. There was a sentinel pine present at 6 o'clock position. Perianal skin showed mild erythema, no external openings in the perianal region, no prolapsed mass. On palpation, severe tenderness at ulcer site was there, mild induration at margins. There was increased anal sphincter tone. Digital rectal examination was deferred due to severe pain. Proctoscopy was also deferred due to severe pain. Abdominal examination, it was also normal. Other systemic examination were within normal limits. Summarizing the case, a 28-year-old gentleman, IT professional by occupation, came with painful defecation and occasional bleeding per rectum for 3 months and constipation for 6 months. On examination, there was a linear longitudinal ulcer at the anal canal at posterior midline 6 o'clock position with associated sentinel pile. And our provisional diagnosis is chronic fissure in ano with sentinel pile at 6 o'clock position.
GMC, you have now 6 minutes, 10 minutes for ask the questions.
Very well presented. First of all, I would like to start by asking you, what do you mean by fissure in ano? What is the definition of fissure?
Fissure in ano is a longitudinal tear from the anal verge up to the dentate line, not extending beyond the dentate line.
Yes, but where is it? It is actually an anal tear in the anoderm of the anal canal. Yeah. So what do you mean by the anoderm actually? So the anoderm is actually nothing but a specialized form of epithelium of the anal canal. It is devoid of hair follicles and anal sebaceous glands. It is lined by modified squamous epithelium. So and as you said, the fissure can extend from anal verge up to the dentate line. So what exactly is the dentate line and what is its clinical relevance?
The dentate line is the line between the line dividing the ectoderm and endoderm. That is the upper part of the anal canal is endoderm, and the lower part is ectoderm.
Above the dentate line, it is lined by the columnar epithelium, and below that is the stratified squamous epithelium.
Yes, yeah, you're absolutely right. To be precise, it is the line of embryological fusion between the post-allantoic hindgut and the proctodium. And its relevance is it is a watershed area where the lymphatic drainage is different above. It goes below it goes to the inguinal lymph nodes, and above it goes to the internal iliac, mesenteric, and para-aortic. Yeah. So what is the most common location of a fissure in ano?
Most common
midline.
6 o'clock
position.
Yes, you're right. But why is it posterior midline? Why is it in that specific location?
The maximum shearing force during defecation acts at 6 o'clock position. It has very less blood supply compared to other region.
Yes, it has less robust blood supply, and
Right.
also the anatomy of that region, the anorectal angle also causes it to produce a tear there. And do you find an anterior fissure? And
It is,
Yes,
yes, it
it's
is
most
seen in
commonly in females.
yes,
Age
yes,
12
you're right.
up to
Females, yeah,
65.
following obstetric trauma. Yeah.
Okay. Now, coming to your history and clinical examination, you were telling our patient had experiencing severe pain, right, while defecation?
Yeah.
Okay. Actually, what's the mechanism? What is the cause behind the pain? What's it causing the severe pain? Yeah.
Spasm of
Ah,
intestinal structure.
yes.
And
Yeah. What the spasm?
ischemia and
Hmm. Yes, correct. This pain cause spasm. This will cause ischemia, and that is precipitating the pain. Okay. So in our case, it is what's acute anal fissure, right? No, chronic anal fissure.
chronic fissure.
Okay. How typically a chronic anal fissure is presenting to our OPD? Is there any associated any other clinical features? Typically,
Patient
rather than pain.
usually
Rather than pain.
defecation, which lasts up to 2 hours after defecation.
Patient may have history of any discharge from the wound, and local pruritus may be present due to a discharge. And the history is usually long, lasting usually more than 2 months in duration. And
Chronic constipation history would be there.
Yeah, yes, correct. The typical triad is a presence of a lump, that's our sentinel pile, and also discharge and pruritus. Okay. So what is this sentinel pile? What is it is actually, how it is present, how it's
It is a
forming
skin
the.
tag. It is a skin tag which is formed due to chronic fibrosis of due to this fissure.
seen distally to the fissure.
Yes. The reepithelialization, actually. The repeated trauma, then again reepithelialization. This cycle is continuous. That edematous skin tag is actually sentinel pile. Okay, correct. So, in clinically, what we'll find in case of a chronic fissure? What's the clinical triad? In clinical examination, what we will get?
We'll get a sentinel pile, hypertrophic anal.
Yes.
And a longitudinal ulcer.
And a longitudinal ulcer
in the
with
anode.
indurated edges, and we can see the internal anal sphincter fibers at the base of the ulcer.
Yes, correct. Yes, correct. So, is it relevant to examine any lymph node enlargement in this case?
Yes.
Any lymph node?
In the chronic infection, there may be a reactive enlargement of the inguinal nodes may be present.
Yeah, in infection and also in some sexually transmitted diseases also there may be presence of inguinal lymph node that will change our management. Okay. So in case of if the
So you guys had so we have discussed about posterior anal fissure, which is the most common location. We have also briefly talked about the anterior fissure. So now let's talk about atypical fissures, right? So what is an atypical fissure? When would you say a fissure is atypical?
If the fissure is not occurring at its typical position, midline, posterior midline, mostly lateral and multiple in number.
Yeah, and also in immunocompromised patients, right? So these are the red flags for fissure. So when these happen, what are the extra things that you might have to do in ask history, and also what are the extra things that you will have to do in investigations?
We would ask about high risk sexual behaviors.
History of altered bowel habits, which may be present in IBD Crohn syndrome.
Yeah. All right. And how will you like? Was there your investigations will change anything?
Yeah, we should examine
that
patient under anesthesia.
We have to rule out any. We have to do a sigmoidoscopy or colonoscopy to find any other lesions within the.
So you had talked about examination under general anesthesia, right? So what are the other reasons apart from atypical fissure in a patient presenting with fissure to do an examination under general anesthesia?
Suspecting malignancy.
Well, you had asked very rightfully examine for pallor, right? Fissures don't typically cause pallor, right? So if a patient is having pallor and an anal fissure, then that would have to make you have to do a faster general anesthesia examination and even a colonoscopy in that for that matter, because fissures are not going to typically cause a paler. And another thing is
You
also
you have
when the
a
patient
minute
is having
more. You have
atypical
a minute
history,
more.
tenesmus and all other things.
Weight loss
Okay.
history, weight loss, anemia.
Yeah.
So you've arrived at a diagnosis of chronic anal fissure for your patient. How will you manage this patient?
First, we had to advise lifestyle modifications, fiber-rich diet, and increased fluid intake. Then we can give topical analgesics like topical lignocaine.
First line is always conservative management, and if it fails, we'll go for topical agents. And if that fails, that is like a chemical sphincterotomy. If there's still recurrence or if the mode of therapy fails, we'll go for surgical intervention, which is lateral internal sphincterotomy.
Okay. So if you have decided that you're going for your conservative management has failed, what are the agents that you use for in your medical management?
We use GTN, diltiazem,
Nifedipine. We can also use botulinum toxin.
topical botox injections.
Okay. For this botulinum toxin, can you explain the mechanism of action, how it causes, like how does the patient get a relief?
Release from the nerve endings, which would relieve the muscle spasm.
The internal.
Okay. Wait. Okay. So if you go for, you talked about glyceryl trinitrate as well. So what is it routinely used?
It's so at present the most used agent is diltiazem. GTN causes headaches due to systemic hypotension, so it's mostly avoided in pregnant women.
Mostly
and
avoided, yes.
Yeah.
Good. So what will you decide if there is something called as failed medical management? What is the next step in the management? And also, can you define what is failed medical management?
So failed medical management is 2 trials of topical diltiazem, GTN, and nifedipine. And then if that fails and the patient does not want surgery, we'll go with 2 trials of Botox. If the patient is willing for surgery, we'll go for lateral internal sphincterotomy.
Okay.
And
ideally, there's also a time frame of 6 to 8 weeks. That is a maximum time that you can give for medical management, following which you go for surgery. So what is the surgery that you'll do here?
we'll do lateral internal sphincterotomy.
So can you explain the procedure of lateral internal sphincterotomy?
So we we find the Hilton's line, which is the line of demarcation between internal anal sphincter and external anal sphincter. There are 2 techniques, open and closed. So in closed technique, we open the mucosa and we find the fibers of internal sphincter and we cut through, which is like, so we can see it clearly.
And also, is there any specific guideline about the length of anal sphincter that you have to cut? Like how much of the anal sphincter will you remove?
Below the dentate line, or the upper end of the fissure, whichever is lower.
So you've
Thank
done
you
your
very
lateral
much.
internal
Thank you very
sphincterotomy.
much. Thank you very much.
What is the complication that you're expecting in your patient?
Thank you very much. We would like to move to the last.
Most common complication is pain.
Thank you.
Sorry?
We'd like to move to the. Thank you. We'd like to move to the next set of.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you all. Thank you.
And we come back with the
MES KMCT.
MES versus KMCT. Can MES come in?
Yes,
Say
sir. Am I
hello to-
audible, sir?
Yes,
Yes,
very
yes, you're
much.
audible.
So KMCT also please come in. KMCT, please unmute yourself. There is one more person in KMCT, only 3 people are there. Come closer. No, I can't, we can't see the 4th person. Okay, fine. Let me just make the presentation. Yeah, that go on with your slideshow.
Okay, sir. Good evening, everyone. Today, I am presenting a case of 34-year-old female patient who is hailing from Manjeri, who is a homemaker by profession, coming with complaints of painful itchy swelling over the front of the chest since 10 months. History of presenting illness, the patient was apparently normal 12 months back when she developed pustule over the front of the chest. The pustule ruptured on its own after 1 week, following which a swelling was formed at the site. After 2 months, a small swelling appeared over the scar. It gradually increased in size. She also noticed that the swelling spreading beyond the boundaries of initial wound. She also complains of itching and pain over the swelling. The pain was insidious in onset, aching in nature, intermittent, and resolves on its own. There was no radiation of pain. No history of ulceration, discharge from the swelling, or rapid fungating growth. No history of fever, no history of other swellings elsewhere in the body. Coming to past history, no history of similar lesions or delayed wound healing elsewhere. No history of radiation exposure in the past. No history of TB or type 2 diabetes mellitus. No history of drug allergies. No history of any trauma in the past or drug intake. Coming to personal history, the diet is predominantly non-vegetarian, normal sleep and appetite, normal bowel and bladder habits, no other addictions. Coming to family history, mother has a similar thick scar on her left earlobe following piercing. Menstrual history, menarche at 14 years, regular cycles, no dysmenorrhea. General physical examination, patient was conscious and oriented to time, place and person. Patient was examined in a well-lit room after adequate exposure after taking consent. Patient is well built and moderately nourished, BMI of 21.4 kg per meter square, ECOG score of 0, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema. Vitals, pulse rate was 86 per minute, regular rhythm, normal volume character measured in left radial artery in sitting position. Blood pressure was normal, 120 per 70 millimeters of mercury. Respiratory rate was 16 per minute. All peripheral pulses were palpable and was afebrate. Coming to inspection, a patient is examined in supine position with arms by the side. A single well-defined swelling of size 5 into 3 centimeter present over the pre-sternal region, 5 centimeter below the suprasternal notch in the midline. It is irregularly shaped. The surface appears smooth. The skin over the swelling is stretched, shiny, dark pigmented in color with no hair follicles. It was well-defined irregular margins with extension into surrounding normal skin. There was no sinus, ulcerations, or satellite lesions. On palpation, no local rise of temperature, mild tenderness was present, hyperesthesia is present over the swelling. Inspectory findings were confirmed. It was firm and rubber in consistency and of thickness of 4 millimeter from the skin surface. It was non-compressible, non-fluctuant, and non-transluminant. Skin not pinchable over the swelling, and the swelling is freely mobile in both vertical and horizontal direction over the underlying sternum. There was no palpable axillary lymph nodes. On auscultation, no growing was heard of the swelling. This examination were within normal limits. Condition was normal. Summary, a 25-year-old female patient presented with slow-growing, itchy and painful swelling over the pre-sternal area for 10 months following rupture of a pustule. Examination revealed a 5 into 3 centimeter firm and rubbery, tender, irregular shaped swelling with smooth, shiny, hyperpigmented skin that extend beyond the original site of scar, with skin not pinchable and is mobile in both vertical and horizontal direction, and there is no evidence of local infection or regional lymphadenopathy. So, our provisional diagnosis is keloid or the pre-sternal area.
MCT, can you just make questions? You're muted. Please unmute.
What are the differential diagnoses of the keloid?
One is hypertrophic scar, dermatofibroma, then dermatofibrosarcoma protuberans, pyogenic granuloma is another differential diagnosis, and then scar sarcoidosis.
The most common sites of keloid and why it is happening in such sites?
Because of the increased tension at these sites, which leads to the at the sides of sternum in the shoulder, there will be increased tension lengths and it causes the proliferation of fibroblasts and causes keloid formation. It is a risk factor for keloid formation.
What are the most common sites? Most common sites?
It is sternum, the shoulders, and in the ear, and also in the upper back and on the trunk region.
And regarding pinna, what is the pathology?
There is increased collagen synthesis and there is immature fibroblast proliferation. That's leading it.
There is increased extracellular matrix deposition. Proliferation of more type 3 collagen.
Usually, there is increased chance of ear piercing in the pinna region And following ear piercing, after the trauma, the wound heals by forming a keloid.
In ear piercing, there is perichondritis ulna. It also induces keloid formation. The most common etiology is inflammation over the ear. That is why also ear is the most common site which shows a successful rate for treatment also.
So what is the word meaning of keloid? What are the symptoms associated with keloid? Hello.
The videos is stuck. Hello. 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 Hello, sir. Can you hear us?
Hello. Very much audible. Both of you are very much audible. Keep talking.
Okay. Name some symptoms associated with keloid.
Ehlers-Danlos syndrome. Ehlers-Danlos.
Sir.
Ehlers-Danlos syndrome and scleroderma.
Okay. Some other symptoms include Bruchstein Thyroid syndrome and multiple hereditary exostosis are also there. Symptoms associated.
So how do you manage case of keloid?
Non-invasive measures as well. The non-invasive measures are preferred first. In that, you can use surgical prevention. You can start with wound taping and sequences for prevention. Once the keloid occurs, conservative manner.
MES, your sound is broken. Can somebody come closer to the microphone? Whoever is answering.
Muffled. No.
The preferred treatment is a multimodal approach. There are non-invasive as well as invasive methods for treatment of keloids. When you think about prevention before the keloid occurs, you can start with wound taping to reduce the tension. And then you can use non-invasive techniques. The most commonly used ones now, it's a multimodal approach, but most commonly ones now used now are triamcinolone, acetonamide, and 5-fluorouracil injection over the keloid side. You can use, there are other options such as bleomycin, imiquimod, which is an immune modulator. And then there is invasive techniques such as intralesional excision of keloid, which is usually done in combination with intralesional steroid and 5-fluorouracil. Also, cryotherapy also can be used.
Also, silicone gels can be used to improve the hydration and also to reduce the keloid formation. And also, postoperative radiotherapy can be given 24 to 48 hours after the surgery to reduce the keloid formation.
So what is the maximum effective dose of radiotherapy used?
30 to 40.
Okay. Suppose in a patient who is planned for total thyroidectomy and who have a history of keloid, so how will you proceed?
What are the precautions you will take?
So first of all, we will try to put the incision along the Langer's line, and post-operatively we can usually do the wound taping, and the pressure taping should be done. It should be worn 24 hours for at least 3 weeks, 3 months post surgery, and also silicone pressing can be given to increase the moisture, and also we can do to avoid hyperpigmentation. We can give some SPF 50 sunscreens to avoid hyperpigmentation. And also after once the wound starts healing, we can give corticosteroid injection also to the wound site.
We can also attempt minimal invasive surgery for that also, like transoral or transactional.
Posterior-auricular approaches.
Can you name some scoring methods for scars? Fitzpatrick scoring. Yeah, the name it goes like Vancouver staging, then Fossa staging.
It most commonly use the Van Gogh staging for scars. Then we have visual analog scale, then staging. So you told for we can use compression, stockings, etc. But in case of ear, how we give a compression? It is
We
in
will
case
give
of
pressure.
Yeah,
We will
magnetic
give
studs
pressure
could be.
dressing. Okay,
magnetic
the pressure
studs.
dressing will be given as magnetic, and it will
Magnetic
cause
studs.
ischemia and reduce the proliferation.
Okay. So what is the mechanism of action of silicon compression? How it is helping in reducing the keloid formation?
It
So the
hydrates the
one
stratum corneum and it reduces the cytokine release, and also thereby it decreases the fibroblast proliferation, thereby decreasing the keloid formation.
Also
Along with that,
reduces
it
the
is
loss
also
of water that we have.
See, makes the wound hydrated.
It also makes the increase the temperature and decrease the collagenous activity. Thus reduces the collagen synthesis, and it's also a mechanism. In case of cryotherapy, how it is going to help?
Cryotherapy softens the lesion. So when we apply topical cream after that, it helps for better penetration.
And also ice crystallization happens while giving cryotherapy. And after that, we are doing transluminal injection. It will be it become more softened.
Because keloid
Your
is
last
hard, no?
question.
So
Your last question.
It actually causes hypoxic injury. Yeah.
Okay, then we'll move to the next team. KMCT, you can make the presentation. KMCT. KMCT, the person who is on the right extreme side is not visible. Come closer. Yeah, that's fine. Can you share the slides, please?
Yes, sir. The present. Share screen. Share. That's good. Share. Good evening, all. Presenting the case of Raju, 34-year-old male hailing from Mukkam, who is a driver, present in the OPD with the chief complaints of pain and swelling in the perineal region since the last 3 days. History of present illness: patient was apparently normal 3 days back when he noticed pain and swelling in perineal region 3 days back. Just acute in onset, throbbing type, severe pain in the left buttock, aggravates on sitting and defecation. He also notices swelling in the left buttock close to the anal opening, gradually increasing in size. He also has difficulty in sitting and walking. There is no history of any trauma, no history of fever or discharge of pus, no past history of discharge from pus in the perineal region, no history of constipation, diarrhea or tenesmus, no history of evening rise of temperature or weight loss. Moving to past history, there is no similar history in the past, no history of type 2 diabetes mellitus, hypertension, coronary artery disease, bronchial asthma and tuberculosis, no history of any inflammatory bowel diseases, no history of malignancy or radiotherapy or chronic illnesses, no history of previous anorectal surgeries. Personal history: patient is having a normal sleep and appetite with regular bowel and bladder habits, no addictions. Family history: no significant family history. Moving to examination, patient was examined in a well-lit room after taking consent with adequate exposure. Patient was conscious, oriented to time, place, and person, and cooperative, well built and nourished, with a height of 171 centimeter, weight 80 kg, and BMI of 27.3. Karnofsky performance score is 90. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema.
Can you go to the local examination? None of these things have got any bearing. Please go to the local examination.
Stable vitals, and moving to local examination. On inspection, erythematous swelling 2 centimeter from anal verge at 4 to 6 o'clock position. Perianal skin, there is no external hemorrhoids or sentinel piles, no fissure or fistula, no active discharge. Palpation, local rise of temperature present, tenderness plus and fluctuation also present. Induration present over the surrounding area. Digital rectal examination was painful, and systemic examination was within normal limit. Summarizing, 34-year-old male presented to the OPD with pain and swelling in the perianal region since the past 3 days. On examination, there was a tender fluctuation swelling at 4 to 6 o'clock position with a local rise of temperature and erythema. And it's a provisional diagnosis of perianal abscess at 4 to 6 o'clock position in the left buttock.
Yes, you have, please. You have 10 minutes here.
Okay, very good presentation. Okay, at the end of the history, you have came to diagnosis of perianal abscess. So, how will you substantiate the diagnosis looking into your history and also examination? Which all factors do you keep to substantial diagnosis?
Acute onset of pain and swelling in the perianal region close to the anal verge. On
It is also
tender fluctuant swelling.
Also aggravated during defecation and also by sitting and all. And throbbing perianal persistent pain. So, have you heard about any etiological theory regarding this perianal abscess?
Cryptoglandular theory.
Okay, what is cryptoglandular theory?
It is actually the inflammation of the anal crypts, which later progresses to form perianal abscess.
Actually, the anal glands present in the sphincteric space, draining into the anal at the dentate line, causing clogging and infection and leads to the perianal abscess. Okay.
So, can you tell me where are the glands specifically located?
Sorry? Can you repeat the
Where are
question?
the anal glands specifically?
The dentate gland. Yes, below the endocrine.
Actually, it is in the intersphincteric plane that opens into the crypts of the dentate line. Can you tell me where is the dentate line located?
2 centimeters above the anal verge.
Yes.
What are 4 primary anatomical locations for perianal abscess, anorectal abscess?
Can you repeat?
4 primary anatomical.
Your voice is breaking. Sorry. Hello? Hello? So the video
Problem is that the problem is that they have come with 2 devices, one for voice and one for visual. So there is a problem. Can you repeat
What
your
are
question?
primary
Can you
anatomical
repeat your
locations
question?
for anorectal abscess?
Is it audible?
Yes.
Okay, the answer is perianal, ischiorectal, intersphincteric, and supraelevator.
The person sitting in the middle back is sitting from very far and asking questions. Nobody can hear your questions, boss.
Can you repeat the question?
Is it if it is a recurrent perianal abscess, what will you suspect further?
Fistula in anal. In case of recurrence, we have to rule out malignancy, then inflammatory bowel diseases and other.
What are other things you should
You have
work?
to look compromise the diabetic side of diabetes.
Control.
Okay, TB and rectovaginal fistula and uterus.
Plus gonorrhea, LGV, syphilis.
Can you tell the boundaries of ischiorectal fossa?
Ideally, it is bounded by the elevator anal muscle, part of elevator anal muscle, and the rectal mucosa. Then apex is formed by the white line. A base is formed by the skin and subcutaneous tissue. Posteriorly, it is Laterally, ischial tuberosity and obturator internal muscle.
Medially, that is external
Medially,
anesthesia.
How is the perianal abscess spread to the contralateral side?
Posteriorly, there
Yes,
is
especially osteoabscess.
posteriorly there is communication.
Through deep postanal space, and then it is called osteoabscess. So, suppose if there is induration and tenderness, and there is no fluctuation, so what does it mean?
Theoretical abscess actually may not have with the fluctuation may not be present. Make it easy. So we have to go for an MRI. It's needed actually.
It could also be a perianal phlegmon. Yeah. So, what will be the plan in a perianal phlegmon? How will you manage it?
Perianal abscess.
Or if it, in a evolving perianal abscess?
Managed by incision and drainage. We won't wait for an abscess to form because patient will be symptomatic, so we have to symptomatically manage the patient. So we go for an eye.
Well, are there areas where you won't wait for fluctuation to form to do an IIT?
What are the other areas where we won't wait for fluctuation to do an IND?
Radius, parotid.
Breast abscess also. Any opinion regarding the digital rectal examination in this patient?
Rectal abscess, we can feel bogey swelling. Usually, it will be painful. We can examine under anesthesia. It will be more better. Rectal examination, patient won't be cooperative since it's very painful. So, better to do a examination under anesthesia.
Okay, we can also assess the internal opening.
If you examine under anesthesia, what openings are you looking for?
We look for the internal opening or any deep-seated abscess.
Mucosal bulge, malignancy. We can also identify it is supralevator.
For intracerebral abscess can be identified. So, are you interested in looking per-abdomen examination in the case of a perianal abscess? If so, what all are you looking for?
Looking for malignancy. We can feel a swelling mass or per-abdomen examination in inflammatory disease. We have tenderness of the abdomen, then pelvic inflammatory disease in case of TB. So TB, that case also we can get abdominal examination by this. Then
We should also look for any local rise of temperature.
Okay, then how will we proceed in this case?
Proceed with the incision and drainage.
Every abscess should be drained actually. We do go for a cruciate incision to drain.
So while putting a cruciate incision, what all things should be kept in mind while we are doing this cruciate incision?
Incision should be near to the anal verge.
What is the significance of that?
So already
we can avoid a non-vacuum.
With the fistula, we can remove the fistula. Then, while counseling the patient, what are the three main things that you explain to the patient while doing an IND in perianal abscess?
Regarding fistula formation and long duration of wound healing. And
mainly
recurrence. If it is recurring, we have to go for if you go to introverted policies, we will have to do a colonoscopy. Or if it is recurring, we have to go for fistula formation. We will have to go further in investigation.
Is routine packing recommended? Is routine packing recommended in these patients after surgery?
Soon after surgery, actually, we pack the patient to avoid.
Actually, light packing is done. It is to control
drain, permit the drainage.
For primary hemorrhage, we can give a packing for 24 hours.
And then 6 bath also.
We will address the patient
Should be
regarding
avoided in these days. So, what are the other? Here, the patient presented with perianal swelling and pain. What are the other ways in which the perianal abscess can present?
In supralevar abscess or deep-seated abscess, patient can present with malaise and generalized fever with anorexia or systemic features. There is no.
The patient actually can present with the pus discharge from the anus itself, that is ruptured in the anal canal. And also on examination only we can get a submucosal abscess with no perineal component. That two ways also patient can be presented.
Last question.
What is the significance of asking any previous surgical history? So can you name the surgeries?
What all surgeries you ask?
Previous.
History.
There is a history of fistula surgery.
Any previous IND history?
That's any sclerotherapy, any biopsies, or any hemorrhoidectomy.
Okay, then thank you very much, all the teams. I now request.
Thank you, sir.
Thank you very much. I now request quick comments from Professor Karthikeyan, sir.
Yes.
Sir, you have come through screw devices.
Okay.
Bharatiya sir ഒരു സിനിമ സ്റ്റൈലാണല്ലോ എക്കോ ആണല്ലോ
Now is it okay?
No, sir, രണ്ട് device ഉണ്ട്. We'll have Rajan sir coming in. Then we can switch off one.
Nice small short cases being presented. ഒരു 5 മിനിറ്റ് ഒക്കെ തന്നെ ശരിക്കും കൂടുതലാണ് സമയം കൊടുക്കണമെന്നാണ് എൻ്റെ വിശ്വാസം for these type of cases. Anyway, well done. All the groups have done well as far as the presentation of the case is concerned. Questioning ആണ്, that is where we really assess the candidates as a teacher. അപ്പം അതിൽ മോർ ഓഫ് തിയററ്റിക്കൽ ആസ്പെക്ട്സിന് ചില ആൾക്കാർ കൊടുക്കണം. Some people, we have of course marked according to the system as Dr. Karthikeyan has suggested. We will finalize the complete results tomorrow and give the total number of 8 after the number of presentations done after tomorrow.
Thank you, sir.
Right.
Certain very little things are there which are lacking. One spelling mistake is there. It's not scaring. Not instead of scarring, written scaring. That meaning is different. Then one is the age. They have not given the importance for age. And another LP, they specifically mentioned that there is no venous engorgement of swelling over the left scapular area. Why? They haven't asked about why you give so importance to that. And never asked about the liposarcoma, which is the most common site of liposarcoma. That was not asked. And that's it. Which are the other areas you can get? All areas except palm and sole is the area where you get a lipoma. That also minimal thing. And a thrombosed hemorrhoid, definitely, that's the only one emergency condition in hemorrhoids which needs emergency surgery. Give a little local and evacuate the clots. Definitely, otherwise the patient won't be able to sit. And then regarding, yes, a certain points just I mentioned, okay, it was good. Anyway, all presented well, right?
Thank you, sir. Dr. Ravishankar.
Sir, as sir told, all the discussions were excellent, closely fought. But as Rajan sir told, there was too much of theory into it. And in the second discussion for the lipoma, to the extent they went cytogenetic studies for a small subcutaneous lipoma, that is a little bit too much, I think. So too much of theory into it. And all the teams fared very well. Congratulations. And as so told, I will pick the best 8. Thank you, sir.
Thank you very much. We'll meet tomorrow. My only request, which I think Madhu and Dr. Bibin will convey to the candidates, is at least they should avoid all technical hitches They must know how to share the slides, and they should come in time with good connectivity and good laptops. Otherwise, they will lose unnecessarily the time. Thank you very much. We will come back again for tomorrow at the same time.
Thank
Madhu,
you.
anything
Okay.
for it?
Good night. Good night.
Good night, sir.
Good night. Good night.
Okay, good night.
Right.